Good evening, Manju. Nice to see you.
Good evening, ma'am. Nice.
Can I start?
Yes, doctor.
Namaste.
Namaste.
I'm Dr. Ranjan, neurologist at the Indraprastha Apollo Hospital. And I think it's my pleasure and honor to be here today when we are talking about transforming care at the bedside. APO, as we all know, is a non-profit organization started in 2011 by Padma Vibhushan Pratap Siredi, chairman of the Apollo Group of Hospitals. The aim of this organization was to bring together 1.4 million physicians of Indian origin in the world on one professional platform. This substantial workforce of physicians is a valuable resource which may help to mobilize significant developments in healthcare globally as well as in India. And I'm so glad and happy that our chairman's vision is actually transformed in what he thought of. Transforming healthcare at the bedside. And as a person who's a neurologist, I would say is the biggest challenge for us as neurophysicians. And I, being a person who is interested in stroke, where any neurological care, any neurocritical patient, any stroke patient, his values, his outcomes can be transformed by good bedside care by our nurses. I always give small examples when I go for a round that you see there's an intelligent nurse who tells you if the patient has a DVT, if the patient has a dysphagia, what should be done about it. So I personally is of the very, very strong opinion that the nurses, the bedside nursing in critical care and stroke can transform the health of our patients. I end by this by handing over the proceedings to our chairperson, whose biodata is of course very, very impressive. I don't know where to start and where to end, but to cut things short, Sri Devi Balachandran is a lecturer at College of Nursing Sultan Qaboos University, Muscat in the Sultanate of Oman. Mr. Sri Devi Balachandran has extensive experience in India, UK, and Australia. She has also worked as the ex-director of nursing at a prestigious 100-bed hospital in Bangalore, India. She is a versatile nursing educator with 24 years of experience in nurses education. And I'm sure her being the chairperson of this conference would really add millions to improving and transforming nursing care, healthcare on the bedside. I wish the deliberations a grand success, and I hope that we can further go ahead to improve and transform nursing care at the bedside. Thank you very much, and thank you very much, Dr. Usha Banerjee, for giving me this opportunity to come and speak to all of you. God bless and take care.
Thank you very much, Dr. Ranjan, for that kind introduction. And as a neurologist, you mean a lot to us on today's deliberations because, yes, it's a team that works together. So without further spending time, good morning, good afternoon, and good evening, because I'm speaking to you at 8 p.m. from Sydney, to all our listeners. Before I begin, I would like to extend our gratitude to the Global Association of Physicians of Indian Origin as an organization on my personal behalf and on behalf of the organizing team in the nursing for providing a platform to the global nursing community to present the third of a series of GAPIO Nursing International Lecture Series for 2021-2022. The nursing team that collaborates with GAPIO to make this day happen is led by none other than Dr. Usha Banerjee, the Chief of Nursing for the entire group of Apollo hospitals, who happens to be a great friend of mine, as well as our association has lasted, it's probably more than 20-25 years old. Along with her, we have a senior colleague, retired Major General Elizabeth John from the Army, who also happens to be Usha's teacher, and my very own teacher, Dr. Agnes Therady from the USA, who is also a very inspirational person and a mentor for me, and has been for a long period of time. And my close colleagues, Miss Lalita Goel from UK, Dr. Rita Lakhani, who is one of our moderators today from Bombay, and Dr. Manju Pallam from the UK, who is also the speaker for today. Today's theme, transforming care at the bedside, is apt for all of us nurses. While we grow in our nursing education and leadership abilities, the outcome must see, I believe, care being transformed at the bedside for all our patients in the public and private hospitals in the Indian context. The corporate hospitals of all types, starting from Apollo, have surely been able to make an impact and to have some premier institutes such as PGI, Medical Education and Research, Chandigarh, and Sri Chitra Tirunal Institute for Medical Science and Technology. However, in the Indian context, nurses are yet to make an impact on the common man in a general sense. This has various reasons. However, it is the right time to rise to the international level of nursing care provision. COVID gave us a great opportunity to exchange practices constantly in the past 2 or 3 years with our Western counterparts, and we have realized the gaps and opportunities for improvement in Indian settings. We have identified two of our excellent speakers from India, and we have international speakers today for our 90-minute session on transformation at the bedside care. So I will now take my opportunity to introduce our moderators. The first moderator for today is Dr. Rita Lakhani, a student of mine, a colleague from my alma mater, is an SNDT Women's University. She is a great example of an excellent teacher, and she is an excellent teacher because she has a lot of clinical experience. Nursing being a practice profession, I believe that we cannot be faculty without clinical experience. And so she happens to be one of my favorite because she has a lot of clinical experience. Climbing the heights from diploma in nursing to PhD, Rita, with a belief of clinical learning and teaching, she has held academic positions in institutions such as SNDT Women's University and D.Y. Patil University. So her 23 years of experience as faculty, more than 5 years of experience at the bedside in the critical care, she is totally committed to the International Nursing Council's principles of ethical conduct. And she has been credited with educational innovations. A guide and a mentor to students in nursing research, she herself has won the first prize for paper presentation in the teachers category in Maharashtra University of Health Sciences in 2010. and amongst medical and pharmacy category at MUHS in 2015. She recently joined Jupiter Hospital in Thane, Mumbai as the principal of the College of Nursing, and I am looking forward to her setting up a program in nursing, which is par excellence. Rita, over to you, and Rita will introduce our speakers, two speakers for today, and then we will continue with the next moderator. Thank you so much for the opportunity. I thank the nursing team and the GAPIO for having faith in me to conduct this session, conduct these sessions as a chairperson. Thanks again.
Ms. Sridevi, it's a pleasure to be introduced by a teacher as you. I'm honored and humbled. Thank you so much. It's my turn now to introduce to you to a speaker par excellence. So it's my pleasure to introduce to you Dr. Manju C. Palam, my comrade. She's an experienced senior university lecturer, NHS, manager, leader, and quality analyst with international experience in clinical research and innovation, with background of healthcare management, business development, and project management. She's currently working as a senior lecturer in Manchester Metropolitan University. Prior to working as an assistant research delivery manager, and before that, she was working as a quality lead, National Institute for Health Research, clinical research facility at Central Manchester Hospitals. Dr. Manju was also the honorary staff of Manchester University. Dr. Manju is the Northwest lead for the Chief Nursing Officer's Strategic Advisory Committee. She's also the international lead for her university department. She was the first Indian research practitioner at Manchester University Hospitals Foundation Trust and was the first Indian to complete masters from Manchester University and is currently in a senior role. Her research interests are focusing on BAME. She has been described as an instrumental person to bring on change and a pleasant person to work with. She has been featured in the NHS Wonder Woman show and has been described as a Wonder Woman by many of her friends and colleagues. Dr. Manju is a very strong advocate for equality and diversity and has won many regional and national awards for her work. She's here to share her thoughts with us on emotional intelligence for transforming care at the bedside. Most welcome, Dr. Manju. The floor is yours.
Thank you so much. Thank you, Rita ma'am, and of course, Sridevi ma'am. And thank you for this wonderful opportunity. It's my pleasure to be here with my classmate Manju and all the rest of my senior colleagues here. And of course, with the esteemed attendees of the session. I've been tasked with talking around emotional intelligence and patient care at bedside. And as we started with this session, we talked around how do you actually provide care at bedside? And many healthcare systems around the world are emphasizing a need for more patient-centered care, a multi-dimensional concept that addresses patients' needs for information, views the patient as a whole person, and promotes concordance and enhances professional and patient relationship. And some of the time we think about what characteristics actually a health professional needs to actually provide this patient-centered care. And you may think around concepts like personality traits, ideas of multiple intelligences, or having a high IQ, and some of your attitudes and beliefs that may contribute to person-centered care at bedside. And when you think deeply, you then come about emotional intelligence. And it is one of such personal characteristics and is increasingly referred to as having potential role in medicine, nursing, and other healthcare professionals. And here I am today talking around emotional intelligence and how do you use emotional intelligence for care at the bedside. Let me start sharing my slides now, if I have the rights. Okay. Yeah, it's all visible now for everyone. Yeah.
Yes, so, yes, Manju, everything is fine. Yeah.
Thank you. So what is emotional intelligence? It is the ability, capacity, and the skill to identify, assess, and manage the emotions of oneself, of others, and of groups to help guide behavior and thinking in ways that enhance results. So when you break it down, how do you actually use your emotional intelligence to actually influence others so that you get the desired results for whatever you are intending to do. So when you compare it to the bedside care, you are used as a nurse, you're using your skills and capacity and ability to identify and assess and plan and manage the care for patients that you care for. So it's described as the ability to monitor or handle one's own emotions, so your own emotion, as well as the emotions of others. And AI had been in the history for more than 20 years, and it's been used in every business, healthcare sectors, and other sectors, education sectors, etc. Even though people may think AI is a very new concept, it's been around for more than 20 years. It helps you to recognize the feelings, self-monitor yourself, and raise a self-awareness. And how do you actually use your emotions to impact relationships? That's whether it's personal relationship, work relationships, team relationships, or even patient-nurse relationship, and how they can be managed. Of course, it involves motivation, empathy, and social skills. All can be impacted by emotional intelligence. And I have given you some references for this. Okay, so why is emotional intelligence important in healthcare? In healthcare, of course, we deal with patients, starting from patients, and any part of nurse's role is to provide high quality patient care. So how do you actually think about using your AI to improve your performance, to improve your feelings to the patient, to improve the empathy towards that you show to the patient? And also, how do you actually use your intelligence to manage the patient? So healthcare industry, emotional intelligence has been used in variety of forms. And what areas do you have in emotional intelligence? And the emotional intelligence theory, and if you look in literature and in theories, you will see that there are mainly 4 areas of emotional intelligence that you can potentially use for your leadership skills, you as a nurse, and how do you actually influence the patient care. So the first one is self-awareness. So thinking of you as a person, and how do you actually turn your emotions into a better performance, and how do you actually use your emotions to impact your performance. And then you have your self-management. So you then try to regulate your emotions for your better outcome. So say, for example, when you're going to the bedside, you may be in a difficult situation where you have difficult conversations with the patient, and you may feel really sad about it. Say, for example, if it's a cancer patient, you may have your own feelings and empathy towards the patient, which may actually influence your emotions of managing the patient care. So how do you actually manage your own emotions to actually control that situation? Then the next one is your social awareness. How do you actually use your awareness, your personal awareness into social awareness? And then the next step is the social management. How do you actually effectively manage your interactions and try to influence others? So it's a 4 spectrum, and I'll take you into details of each spectrum. So the first one is self-awareness. How do you make sure that you pay attention to yourself? How do you ensure that you actually take care of yourself, your self-care? How do you look after yourself as a person? Sometimes think about, am I well enough to look after the patient? Do I have the ability to manage the situation? Have I got enough, am I, am I competent enough to look after the patient? Do I feel confident to be in that situation? Do I look after yourself? Are you fed really well? Are you hungry? Are you thirsty? Looking after yourself and making yourself, ensuring yourself is aware of your own situations. That is the first key. If the nurse itself herself is not well enough to look after the patient, how would you actually make sure it happens? The next one is, think about these questions. Are you aware of your emotions? Are you aware of how you're expressing them and impacting others? What is the tone of your self-talk? Are you in a hurry? Are you really annoyed about this, previous situation, or with the previous patient or with the previous team member? And are your basic human needs being met? So, for example, your own needs, hierarchy of, needs by Maslow clearly says what are your needs, and how do you actually meet those needs before you actually trying to meet the needs of the patient? And then next comes the self-management. How do you actually manage yourself? What are your interpersonal skills? How productive are you? How you are as a person to be initiating something? Are you authentic? Do you have your own human values? Do you have empathy, sympathy, respect for others? Do you have the integrity? Do you feel confident to care for a patient at the time when you are going to see the patient? So, and there is a list of things that you could actually look at yourself and think around. How do you manage? What is your self-management skills that you have? And always try to reflect on all these skills. Nursing care itself is a reflective journey, and nurses are promoted and prompted to be a reflective learner. So reflective learning doesn't actually occur in a clinical setting. It actually needs to happen within yourself. You need to reflect on your own skills, your own situations, your own management, and your own interactions with others. That includes patients. Think, do I listen to others first to understand rather than rush to respond? Sometimes we are in a very difficult situation and we have to push ourselves. We suddenly jump into conclusion. We suddenly rush into response, even in meetings, even in ward meetings, in clinical scenarios, wherever, even family relationships, we try to jump into conclusions and jump into rushing into respond to that question. And do you have any connection with others? Can you identify the person and name others' emotions accurately? Do you understand others' feelings? Do you see the patient in front of you as a person? And do you understand their emotions? That's the key. Whose work haven't I recognized? Sometimes, a little things that your workmate do, you may not always appreciate. Take time to appreciate their efforts and take time to reflect on positive things. That's the key. Next is the social awareness. How do you understand others' emotions when you are in a group of people? How do you actually use the emotions to your own emotions to understand others' emotions? That is recognizing your emotions, recognizing others' emotions, and responding to others who are distressed. Most of the time, patients end up in hospitals because of their physical or psychological or mental issues and mental illness. And they, of course, will be distressed. And how do you as a person respond to those distresses of the patients as well as the team surrounded by you, your teammates, your ward mates, your leaders, your managers, your colleagues, your students? And how flexible are you and how adaptable are you? So this is a skill. Majority of the nurses always have these skills, and you may be performing these skills without knowing that you are actually using the EI skills. So recognizing your EI skills and using it in a better way to actually support the system, that's the key. Being flexible and adaptable to any situation is the key. And sometimes, if think about an A&E nurse, should be rushing around the patients constantly all the time. And how do you actually make yourself flexible to meet the needs of the service, to meet the needs of the pressures of the service, to reduce the waiting time, to ensure that you provide that emergency care needed for the patient by making yourself and your team flexible for that time and that situation, and overcoming barriers into action. So seeing every barrier, every challenge as an opportunity and using it for your benefit and for your team's benefit is the key. The next is relationship management. And this is not just in nursing, not just in healthcare, it's everywhere, isn't it? How do you actually manage your relationships, your one-to-one relationships, your friendships, your work colleague relationship, your patient nurse relationship? And what skills do you use? And for all of this, particularly in healthcare and in any other sector, definitely communication is the key. And for any relationship, you need to have good communication skills. And sometimes communication is an easy buzzword that's being used by many people and many researchers and many motivational speakers. But how do you actually ensure there is clarity of information? So whatever you're trying to persuade the other person or pass the message to other person, you need to ensure that your counterpart receives it. So there is a clear communication in relationship, in patient and nurse management. So how do you actually do it? And emotional intelligence is a buzzword again used by many, but how do you actually do it? You need to build a culture of listening, whether it's that to the patient, whether that's to your colleagues, whether that's to your seniors, juniors, your students, your partners, your family. You need to develop that culture of listening. Learn to recognize the emotions. If somebody is in distress, somebody is in pain, somebody is actually stressed. And sometimes, nurses are quite good in understanding the emotions, but sometimes because of the workload and the pressure that you have, you fail to empathize to the situation. So you need to actually recognize the situation, recognize the emotions, and then empathize. Set clear expectations. If you are unsure about anything, a situation or a patient management, you need to ask questions. Sometimes asking questions is not harmful, and always a person who challenges gets the more out of the situation or the person. Develop a shared value. That all comes with your human values. Having a human value, sharing your value with someone else, having a common goal, shared vision helps you. If it's a patient nurse relationship, the shared value is the value that you both have. And the ultimate aim of that sharing is to actually ensure that the patient gets the best high quality care that you are intended to give. Be a leader for the situation. Be a leader doesn't mean that you have to have the name and the position and the hierarchy to be the leader. A nurse can be a leader at any stage. The nursing leadership starts from your studentship. And if you look at the Nursing and Midwifery Council, we have actually, the Nursing and Midwifery Council actually clearly says the nurse is a leader at every level. And you have to implement leadership skills from the core, the educational system that you have, from the core educational modules that you have for nursing. And be a leader is the key for EI. Use praise. Sometimes, we are quite good in picking up the mistakes of others, but try to be positive and try to choose and use praises. Develop effective communication skills. And like I said, that's the key for everything. And now there are 3 models of EI. I wouldn't take much theory of it. I would just briefly explain what are the 3 models and why do we use this for nursing and which models do we tend to use. So the ability model is actually, there are 3 models: ability model, trait model, and mixed model. So the ability model is actually around perceiving your own emotion, and you're able to do it. So you have it. You develop these skills and you have it, and you work towards developing these skills. So that is the ability model. So you perceive emotions, you facilitate your emotions, you try to understand your emotions, and you manage your situations, emotions. So these are the skills that you try to develop within yourself. So try to think about your feelings and manage your feelings and emotions in such a way that it is for your better and for the situation's betterment. You then facilitate your emotions. So this is your skills that you develop by altering your cognition or altering your thinking process. So you change your cognition system in such a way that you utilize it for your own benefit. You understand the emotion. So you understand the reasoning with the emotions. Why do I feel it? What is the reasoning? So reflecting on it and actually understanding your own emotions, and then managing it and monitoring your expression as well as others' expression. The next one is the trait model. So me, Manju, I come up with a personality. I have my own trait. And how do I use my own trait? Say, for example, if sometimes I fail to say no, and that is one of my issue, and that's my trait. But how do and that trait, if I want to change it, I have to walk into the ability model to change it. So I use my emotions and my thinking to actually change in such a way that I have to realize I cannot say yes to everything. I have to manage my own situations. That applies to every work situation. So you have to based on my priorities, I learn to say no, and hence I develop my ability model to actually manage the situation. So you have your own perceptions. This is a trait model is part of your own personality, and then you develop your emotional traits. And then mixed model is combination of both. So your personal, your traits, as well as the ability model actually helps you to develop mixed model. And sometimes nurses actually tend to use the mixed models, and majority of the other, businesses, other workers, ITs try to use the mixed model to actually develop your emotional intelligence. So why is it important in nursing? How do we actually, when you break it down to the bedside nursing, what do you actually do? You need to think about patient family centered care, and that is the ultimate. The global nursing workforce is focused around patient centered family care. And how do you provide it? So how do you actually develop that bedside manner? So of course, at the introduction, our speaker said the nurses at the bedside is the key for healthcare. And how do you actually develop? So the person you are going as a nurse to the patient, in front of the patient, you are a person. You hold your personality traits, you hold your ability model, and you hold your mixed model. But how do you actually then use those skills for the better management of patient at that time, at the right time? For that, you may need to have a team of people working with you. You may need to delegate some of the works that you used to do. Try to use your problem solving skills. Learn to multitask when needed. And of course, bring out your leadership and management skills. And EI can be used in all these sectors. EI is not a hard subject. It's within you. You're doing it unknowingly or knowingly. But it's recognizing the EI within you and using it in a better form so that you use it for the better patient care. That is the key. So what are the things that you need to consider? Am I bringing extra patients? And am I assuming the best about others? As a leader, am I being transparent with information? Are my communications frequent, clear, and open to feedback? Majority of the Indian nurses and others, there is a lot of migration happening at the moment. And sometimes our fluency, our language, our speed, the way we talk, our grammar, it doesn't match with the needs of the patient. And there is cultural competency framework for nurses. How culturally competent are you as a nurse? Maybe I'm not the way I should be talking in a British country. I still have my Indian accent, but how do I make sure that my patients, my counterparts, my teammates, my colleagues understand what I say and what I talk? For which I may need to change my skills. I may need to change the way I talk. I may need to change the way I respond. And Indians, particularly, I don't mind telling, when in our education, we always say we are quick thinkers, and our IQ is higher, and we do actually respond quickly based on the things. But sometimes you have to sit back, listen to others, and then respond or challenge. So using your own personality traits and your ability and making it into a mixed model so that you adopt and adapt to the situation wherever you are in. You're making yourself culturally competent to the situation wherever you are in. Am I going slow at key moments, including moments of thanks, empathy, care, and patience? Do we actually appreciate? And one of the good things in English culture is that they always say sorry and thanks. They are very patient. And learning those skills from wherever you are, learning those key skills and using it at the key moments, do I say thanks enough? My kids always say, Mommy, you never say good things. You always complain. Why do we do that? Because that is innate, that is in us. We tend to pick the wrong things. AI just doesn't need to be in healthcare. It's wherever you are, you need to use the AI and making that little change in you, saying, Beta, you did really good. It was really impressing, and changing that, that simple moments into a better things for wherever and whoever you are dealing with makes a difference. And that is the key for AI. How do you show empathy? Sometimes, your colleagues may be having a hard time at home and they can't disclose it to you. But how do you actually understand that situation rather than discreetly going into their privacy? Using your intelligence to manage the situation, providing support for them. That is the key. Perform a simple self-assessment. And if you look around AI tools, you can find many tools to actually look at your self-assessment skills. Take time for self-reflection and ask questions such as, how did that go? How did I manage that situation? I will, after this session, I can go back and think, how did I do? Was I fast? Did I touch the base? Or did I cover the points needed? How was I feeling? Was I ready for it? Did I rush into it? What made me feel that the way I feel right now? Was I able to listen without judging? Was I able to understand the other person's point of view? And that is very key for patient care. Do you always understand your patients? Do you actually always listen to your patients? You are the messenger for patients. The nurses are the key messengers for patients. Are you the voice for your own patients? Do you use your AI to be the voice for your patients? And try simple mindfulness techniques. That is the key that you can do as a nurse. And I have given some tools, and if you Google mindtools.com, you will find a lot of tools to actually understand the mindfulness. And mindfulness, understand the EI. And the EI isn't about doing, huge strategic or managerial or hierarchical things. It's all about how do you actually manage yourself. Maybe 5-minute timeout, or walking in a, forest area or a woody area, working with your friends, or talking to your friends, listening to music, doing yoga, or even sitting yourself calmly without doing something for 5 minutes is actually, is a skill that you could develop for developing your EI. So it's not as, concrete science or a concrete research that you need to develop. Remember that all nurses have the EI skills. It's just that we forget sometimes to use it. Or even when we use it, we don't realize that we are using it. And that is the key. So for you to change your world of patient care, please remember to use your EI. Thank you.
Thank you, Manju, for that lovely session. I think I can just relate with your thoughts. At leadership level, we always say it's easier to work with a person who has got a good emotional intelligence, even if the person has got a little lesser knowledge. So I could just relate with your thoughts that emotional intelligence is just vital for today's world, especially when we have so many stressors around. Even at the college level, when we are working with students, we have always found that students who have better emotional intelligence are able to perform better, and they're able to get acclimatized better at the workplace. I have seen a number of researches where they have shown that when nurses have got good emotional intelligence, and when they are trained, when they are equipped with the strategies and perhaps the framework, they're able to bring out better outcomes. And I could relate with whatever you could say. So I've seen researchers would say that even the infection rate of the patients have gone down. So emotional intelligence is very vital. We need to understand our emotions and handle our emotions. When I look back at a curriculum, there's very little into it, but it is expected that we need to work with our patients with a good emotional intelligence. I think towards the end, you also said to have a look at the tools. It's beautiful. I think we all must go through the tools, because I remember when I was taking a session on emotional intelligence with a group of students, they said it's being vulnerable. It catches you on the wrong side. So I said, no, it really doesn't catch you on the wrong side. It is not making you vulnerable. It is just helping you to know yourself a little more better. And perhaps you'll be able to work upon yourself and grow more. So I think you have just put the thoughts very, very clearly and have uncovered a lot of potential areas for us so that we can work more on these areas. Thank you so much. Let's have a look whether we have any questions in the chat box. Okay, there aren't any questions. So, Dr. Manju, I have one thought. You know, what I feel is as a leader, as a principal of a nursing college, we have multiple roles. We take care of multiple people around us. We are there in the clinical area also managing patients. And when you think of us as a leader, I always think back and wonder whether the decision that I have taken is a perfect decision. You know, we always try and take best decisions, but I wonder whether that was the perfect decision for the person who's in the context. What do you have to say on this?
And that's the key for EI, isn't it? You know, one thing that you're reflecting. And the second thing is that sometimes we forget to put the recipient to the front. So your decisions are always based on your own values, your own emotions, and what you think is best for the situation, without actually thinking about the other person's emotions or other person's values or behaviors. And for EI, that is the key. You have a self arm and you have a social arm. And when you think about the social arm, you have the counterparts and you think about their priorities and their needs. And when you learn to actually balance both sides, your self needs and the social needs, then you are at par and you are actually at the conclusion that what you have taken is sometimes, and people do make mistakes. And again, that is EI. How do you actually then learn from your mistakes? Nobody's perfect in the world, isn't it? So you actually then reflect on your situation and then learn from it. And again, that is a key EI. So EI isn't a science that someone can teach you, or there are tools, strategies to actually help you, but it's actually how you use your own traits, your own skills, and how do you actually mix both of them together to actually manage the situation.
Beautiful, beautiful. Yeah, I agree with that.
Yeah. Thank you, Rita, and thank you, Manju. I think we will have some more questions towards the end. Is that okay, Rita?
Yes, perfect.
Yeah. Okay. I just would like to inform the participants that we have a small change and we apologize for the change. We have one of our speakers has not been able to join. That's our international speaker, Miss Felicia. And so we would utilize that time in the end to ask questions, so participants can put their questions in the chat box. We're extremely sorry for this change because people get sick, and now there is clear reasons for people to get sick, and so we don't have to announce what sickness people have. So we're very sorry about this. We will continue our session for the next two speakers, and I will have the honor of introducing the next moderator for our sessions. So from the international sessions, we have Ms. Dr. Manju Pallam speak, and now we will listen to our very own people who have brought about transformation at the bedside. So I don't want to steal it from Sneha. So I will introduce Sneha to you. Dr. Sneha Vaidya, who's going to moderate the next session of our national speakers, is currently the regional director of Apollo Hospitals for the Western region. So when we say Dr. Sneha, we need to, it's definite that she has a PhD in nursing, and she is a guide to scholars at the JJT University, and she is also a NABH assessor. In addition, she has academic qualifications such as Masters in Sociology and a PG Diploma in Hospital Administration. Dr. Sneha has 25 years of experience of caring, learning, and leading. And as a result of this, she has been credited with improving work scenarios and empowering nurses in hospitals across Mumbai, such as Nanavati Hospital, Leelavati Hospital, and global hospitals. She has a significant contribution in the field of research and publications. She's known to be dynamic and immensely passionate towards delivery of quality nursing care of international standards. Recently, the nursing team at Apollo Navi Mumbai won the Nursing Excellence Award for a CSSD project at the CAHO, or accredited hospitals, community of accredited hospitals, and she under her leadership. So Dr. Sneha will now moderate the next two sessions, and then we will go to the question and answer session. So over to you, Dr. Sneha. Thank you very much for your moderating, and thank you, Dr. Rita, for your wonderful moderation, and to our own Dr. Manju Pallam for your fantastic delivery on emotional intelligence. Actually, I started reflecting because I have been wondering why we were never taught, and I had to learn it the hard way, and I still don't do well on many occasions. And like you said, that's also EI. Thank you very much, Manju. We'll keep the questions to the end.
Thank you.
Yeah, so it is namaste and good afternoon, good evening, and at some countries it is night, and some countries it is early morning. And thank you, Sridevi ma'am. It's really, really wonderful to have you chair this session, and extremely thankful to Usha ma'am for allowing and to give an opportunity to be in this particular very, very important forum, which is very fast and moving in the midst of this COVID. So not taking much of the time, introducing the second speaker for the day, Dr. Shani we have. She has 19 years of stellar experience in her healthcare industry. She is a Joint Secretary, Society of Indian Neuroscience Nurses, holds the membership to AHA and World Stroke Organization. Dr. Shani is an executive committee member, the Nursing Conference, SCTIMST, treasurer TNAI. Of course, she has backed at many research areas where she has been of prime importance in the stroke recurrence, secondary prevention strategies, medication adherence, and risk factor control. And she has several awards and publications to her credit. Over to Dr. Shani for a wonderful session on excellence in care, neuroscience nursing.
Thank you, Dr. Sneha. Good afternoon, all of you. Let me thank Sridevi ma'am and Lieutenant Colonel Dr. Usha Banerjee for introducing me to GAPIO and giving me an opportunity to talk in this international platform. The topic given to me is excellence in care, neuroscience nursing, and I'll be talking on general about clinical excellence and a few points about how to improve care excellence in the clinical area with some examples from my clinical experience. Just a minute to share my slides. Okay. Let me continue with my presentation. Okay, and excellence is the journey, and perfection is the destination. And we can see that excellence is the area where economy, efficiency, and effectiveness meet. Efficiency is the quality, and effectiveness is the outcome, and economy is the affordability of care. So excellence is the care, high quality care, which produce the definite or intended outcome to the patient in a most affordable way, and that will be highly satisfying to the patient. And in care area, clinical experience means ensuring safety of the patients and delivering high quality patient care so that it will bring the desired outcome in the patient, so that we can demonstrate the patients a better and safer place. That is, the healthcare environment can be demonstrated as a better and safer place for the patient that can bring confidence in healthcare among the people. Ultimately, it results in more rewarding workplace for the staff. So general inquisitiveness is very much common to all. As we observe the patient care practices, we may come across deficiencies at times. I can tell you some examples. While receiving a patient after transnasal surgery, and in the next day, we observe that while changing the dressing or a dress of the patient, we observe that the bed linen and patient's dressing all are soaked. That time only we understood that the patient had a lumbar catheter that was dressed inside a dressing, but it was left not communicated to the ICU staff. So that triggered the nurses' inquisitiveness, and what they did is they tried to develop a OT handover checklist so that all the patient care activities regarding surgery, invasive lines, devices, medication, everything can be handed over to OT ICU staff in a systematic way, so that these type of incidents can be prevented in the future time. That is another example is regarding last dose of anti-epileptic medication given in the OT. Everything need to be communicated clearly so that in the post-operative period, seizure occurrence can be prevented. And another example, if you see, sometimes a patient with a meningioma undergone successful resection and received in a very healthy status in the ICU, but after 2 days, the patient died because of a massive pulmonary embolism and resultant of a deep vein thrombosis. So these are the areas which trigger the inquisitiveness of nurses. So what we did is we did a systematic review to find out or develop a protocol to prevent deep vein thrombosis among patients undergone neurosurgery. These are some of the examples we did in the clinical area to improve the care practices of our patients. See, if you see these areas, some problem areas like the ICU handover and all, it is a simple problem, and we need some discussion with the seniors or some head of the department or a head of nursing division. And from our clinical expertise itself, we can develop a protocol or a checklist for handing over the patients. But problems like prevention of DVT and all, we require a multidisciplinary collaboration. That is, we need experts from different disciplines like neurologists, neuro-radio diagnosis people, and from physiotherapy people, nursing department, even a respiratory medicine department to develop a protocol. Like according to the problem, the way of solving will may change. So now we can see what are the components of excellent care. The first and foremost component of an excellent care is high value services. That is, the work culture should be one of care, welfare, safety, and security to all. That is, this care, the care culture need to be inculcated into all the staff, including all categories of staff. And the junior nurses should get motivated from the senior staff, the way they are working. So a culture of care should be inculcated into all the staff. And definitely there should be a focus on education and research. Then only we can constantly improve the patient care practices to the cutting edge. And definitely I have told, based on the clinical area and problem identified, we need multidisciplinary collaboration to find out solution, as well as for a care coordination of care of the patient. The patient care should not be fragmented. Patient should not feel that his care is fragmented. So all the according to the patient's problem, or the department or the necessary departmental team should sit together and plan the care of the patient, so that the patient feel a comprehensive approach towards the solution to their problem. And another important component of excellent care is communication. It has two aspects. One is clear explanation. The patient should receive clear and realistic explanation about his disease condition, treatment options, what are the available options, and the outcome of this surgery or any medical interventions. And another one is listening skill. That is, patient needs to be heard, even if they don't have a skill to speak, they want to be heard. For that, what we can do is the nurse has to develop empathetic listening skills, or at times may stay with the patient to identify what is really going on the clinical situation. And for communication, the another two more aspects are that the patients needs to be patients or their relative needs to be have a up-to-date explanations or information regarding the status of the patient. That is, a patient after surgery or after any medical or surgical intervention, they need their explanation. One example I can tell you, after surgery, being in charge of neurosurgery unit, most of my examples will be from neurosurgery unit or from stroke, since it is my research area. So after neurosurgery, the surgeons himself will meet the patient and explain the conditions or surgical aspects, outcome, present condition, everything. And nurse will also give their own explanations. But in the next morning or next day, usually individual nurses will contact the relatives and inform about conditions. But at times, some patients' relative may be missed out. We may get calls to ICU from them, or at times some of the non-staff, that is, the patient may have some staff working in Chitra, and they will call to inquire the condition. That created a problem or a concern me. So what I did is that I developed a protocol regarding the visiting times and communicating. That is patient information and visiting time protocol, in which we clearly define the times and times in which we communicate to relative regarding patient's condition, and also after that, that problem remain and solved. And another area in which communication needs to be highlighted is that my area is of, I told, it is a stroke. And from my study, what I understood is that the stroke survivors have a poor medication adherence, poor risk factor control, and they are coming with the stroke recurrence. So what we did is we have done a series of studies, and what we could identify that the medication adherence and a poor risk factor control are the reason for their stroke recurrence. And those patients who have a discharge education at the time of index stroke admission have high medication adherence and a risk factor, better risk factor control, and less risk of recurrence. So what we did is that for index stroke admission itself, we were giving discharge education, but we systematically converted it into a form of individualized discharge education. So what we did is we prepared a checklist in which what all the areas needs to be stressed for secondary stroke prevention. And with that checklist, the patient's areas are identified, and the discharge education is planned and delivered according to the individual need of the patient, and it is highlighted at multiple times by nurse, physiotherapist, or a doctor, or even in the OP basis, so that we could reduce the recurrent stroke risk, as well as to improve their medication adherence, as well as to improve their risk factor control status. These are about those publications. And another component of excellent care is patient satisfaction or patient service. I can tell you one example. We were discussing about EI. So sometimes patient may ask to talk to doctor because they don't trust the information we pass to them, and they really want to talk to the doctor. But that is challenging to the nurse credibility. So our the level will change. Our body language, our tone of voice, everything will change, and the scenario will change into a level of aggression. But that should not happen. The nurse has to be professionally trained to identify different types of person and how to appropriately respond with the focus of collaboration and cooperation. Then only we can create or foster an environment in which the patient can learn coping skills to speed up his recovery. That's also very much important for delivering excellent care. And another one is comprehensive and whole person approach or family approach. This I am highlighting because our hospital did not allow the relatives or patient caregiver to be inside the hospital. Once the patient get admitted, the patient will be alone and the relative will be staying outside. So what we can do in this that scenario is that for in the recovery process or even in the rehabilitation time, the patient caregiver need to be involved, and for treatment decisions, choices, also the patient as well as the family members need to be involved. Then their satisfaction will be improved. Then another important area of excellent services or excellent care area is that it should be having a rapid access as well as an open access. Rapid access means the OP should not be having long waiting hours or the surgery waiting time. That all should be minimized. And in scenarios like a stroke, SH, or acute myocardial infarction, or a congenital heart disease, newborn babies presenting to the OPD, they need a separate pathway so that their waiting time or care pathway can be minimized. So some code stroke or a code blue, or like for each and everything, you can have a separate team so that that team can be alerted to speed up their management process. And the open access, which what I mean is that like hospitals, like tertiary care hospitals and quaternary care centers, they usually require reference letters, but they also admit emergencies like heart attack or a stroke. So what we can do is, for those conditions, the referral letter can be avoided. And another one is the emergency contact number need to be circulated widely among the public so that they can contact directly to the care, particular corresponding care areas, and have a better and a quicker admission for their better management. And another important component of excellent care is that staff engagement and wellness. People come into a caring profession because they want to be part of something bigger. They want to be, actually, the nurses are multi-talented. What I understood is that because some are having excellent teaching skills, presentation skills, organization skills, and even they are very singers, dancers, craft, everything. We have nurses in Chitra, versatile. They have all the writers, novelists, even we have nurses who have published books and all. So what the care areas should do is, we have to provide, the staff should be engaged in their corresponding areas of interest. The training needs to be identified, and they have to be deputed in areas whichever they show their passion or dedication. That will create a better environment for staff. And another one is outcome-based care. That is, whatever care strategies we provide or give to the patient, the outcome needs to be assessed. Whatever modification we do in the clinical area, also the outcome needs to be assessed. It can be in the form of staff turnover, patient satisfaction, staff satisfaction, or corresponding patient's outcome of the particular intervention. These are some of the components of excellent care in the clinical area. And the bedside care or care practices are the important one of excellent services. So the effectiveness of care strategies can be assessed in the best possible in terms of their feasibility, reliability, timeliness of delivery, and presentation of outcome, accuracy of outcome, or even patient satisfaction. Because the care practices to be very practical, easy to implement at the bedside. And that should be very much beneficial to the patient. So all the care practices need to be assessed in terms of these aspects. So if you feel that these aspects are not meeting, so you need to have some improvement in these care practices. So improving care practices involves a systematic process, and so few steps can be adopted to improve or achieve effectiveness in the care areas or improve the care practices. So for that, what we need is that we have to know as well as understand the requirement and desires of the patient. That will be basics to any practice change. Then we can identify the newer interventions or newer care strategies, and we have to quantify the strategies in terms of the specification, like the number or frequency of delivery or delivery format, etc. And now we have to identify some target. What are the targets or outcome we are intending to measure after implementation of this care strategy? And then is the execution of this care strategy, and with the proper data collection to make sure that this new care strategy is working. And once we complete this process and the practice change is successful, what we can do is we can document these practices into a form of thing that is called usually the nursing care standard or nursing care pathways or practice guidelines or even standard operating protocols. Successful strategies can be documented as these forms. And these are the path towards clinical excellence. But what we need to see is that are they evidence-based? That need a constant investigation or constant search or a constant research so that we have to push our developed standards or developed protocols into evidence-based level, because evidence-based practice or care combines the clinical the best evidence into clinical expertise as well as patient preference. So the care strategies needs to be pushed towards evidence-based. And this evidence-based practice implementation is also a systematic process and which involves many steps. But for practice change, we need to appraise the quality of evidence or quality of study. Then only we can recommend the level of evidence. That is, at what level of recommendation we are advising this practice change. And before practice change, each practice, new practice need to be observed for its risk and benefits. And by keeping in mind our clinical expertise as well as patient group. That is, the evidence-based new recommended practice need to be re-evaluated in terms of our with our clinical expertise as well as patient preference before implementing practice change in the clinical areas. So that we can expect better outcome and patient cooperation after the practice change. These are about some of the points in improving the clinical outcome or a patient care outcome in the bedside care. And the thing is that the improving care at bedside is always a continuous process. And to conclude, in conclusion, what I can say is that it is a continuous process, and every day a dedicated nurse strive to provide best care to their patients, which require a comprehensive support from the organization as well as their colleagues. And what Aristotle says that we are what we repeatedly do. So excellence then become not only an act, but will be a habit. That's about improving care practices at bedside, the role of clinical excellence. That's about my talk. And thank you once again for giving me an opportunity to talk in this international platform.
Thank you, Dr. Shani. Probably you can close the PPT that is there. I will just go on the touch points, no questions at this moment. It was a wonderful talk, and this is straight from the heart. I can say that because you are a senior nursing officer working in the neuro intensive care unit, so definitely you bring a lot of not knowledge but lot of valuable practices that is encompassed in this particular talk. So just the various touch points that I feel even I learned something in this today's talk. So talking about your study that you have done, the prevention of DVT, the emphasis of the OT checklist, which definitely is just improving day by day, because there are a lot of complications that we see during our intra-operative or post-operative, and we need to emphasize on this. Talking about your components of excellent care, communication, we still need to learn how to be good listeners at the bedside, because neuroscience nursing is something where we feel that patient is lying over there and probably every act that you do, patient is understood, but patient definitely would like to listen to you and to hear from you. One word of that compassion can make a difference in his moments of life. And then you also spoke about the staff engagement, which is very, very important, compassion fatigue, which we often forget, the various effectiveness of care and the application of evidence-based practice, where we need to observe for the risk and benefits. What a wonderful session. And this has really, really encouraged me to put my thoughts probably after this session to think more about neuroscience nursing. Thank you, Dr. Shani, for that wonderful session of yours. Over to our next speaker. This is Dr. Manju Danpadi. I can talk about her. It's a big essay of her credits that I can say. So good evening and namaste, early morning, night to everybody, to this third speaker that I have with a 22 years of vast experience ma'am has. She has won many accolades to her publications and scientific papers. She has been selected globally among 100 nurses by women in global health in collaborations with WHO, ICN, ICM, UNPFA and nursing now as a part of the Year of the Nurse and Midwife, December 2020. She is a doctoral committee member at Baba Farid University of Health Science, Punjab. She is a PhD examiner at Indian Nursing Council, PhD Consultorium, and many other universities. She has 95 publications to her credit. That's wow. That's really wow. She is a course director of Virtual Stroke Nursing Certification course. She has initiated the first stroke survivor and caregiver support group. Top 10 finalist. She was selected as a top 10 finalist for Aster Guardians Global Nursing Award. Her contributions to neuroscience is praiseworthy. I can go on, but the time is limited. And therefore, I would like to hear from ma'am that what is the message that ma'am would like to deliver today to this audience. Ma'am, over to you.
Thank you, Dr. Sneha, for the kind word of introduction. So I am really humbled by that. First of all, I would like to thank Japio and the organizing team, Dr. Sridevi, Dr. Usha, Dr. Rita, Dr. Sneha, Dr. Manju is my friend, and others I have not seen personally, but I'm really associated, I think, through this online platform which COVID has brought in front of us. So thank you once again. Today I'll be talking about evidence-based innovative neuroscience nursing practice. Let me share my slide. I hope the slide is visible.
Yes, Manju, it's fine.
Yeah. So my topic today is promoting evidence-based innovative neuronursing practice. So we know that there is a lot of gap between research, what we do in research and what we learning during our nursing education and practice. And the best way to fill that gap is evidence-based nursing practice. So before going to the evidence-based nursing practice, I would just like to give a small example which I observed yesterday. Actually, I was conducting a practical exam in a hospital where I went to burn ward and where I found a patient's family caregiver trying to make an occupied bed where the patient is sitting and he's trying to make the patient to sit and or partially stand, and the patient is screaming with pain, crying with pain, and the patient is trying to remove the bed sheet from the head end, and he's trying to pull out that bed sheet by making the patient to stand. There is a nurse who is standing at the bedside and documenting something, and the student nurse who is simply standing, maybe waiting for the examiner to come. However, so it was really painful to see. I hope you understood the wrong technique the caregiver was using for changing that bed sheet was from the head end and making the patient to sit when the patient is in so much pain. I just told the student nurse, you please do the occupied bed for this patient the way you have learned, and then you come back to me. Can't you see that the patient is screaming with pain? And at the end of the exam, after everything, she came to me and told, and while I was also observing what is happening while she was doing, so she told me, thank you so much, ma'am, because that patient did not have any pain when I was doing the occupied bed, the way we have learned for that patient. So these are the simple mistakes or ignorance or the lack of assertiveness or the gap we are creating between the nursing education or the research and practice. So we need to fill it. Otherwise, nursing will not stand anywhere, especially in the countries like India. So we know that in Western countries and even like every European countries, the nursing practice is very good. But in India, we need to still improve. We have a lot of nurses who have capabilities, but maybe lack of policies, guidance, and lack of evidences or lack of ability to explore the evidences. But we can't say that now that much because now the things are changing. A lot of change is happening. It was so, but now things are changing. Now, you know, there are 630 colleges that even provides postgraduate program, and around 10 to 14,000 postgraduate nurses pass out every year in India. But where are they going? Are they being effectively utilized? Their skills are being effectively utilized. Aren't there any, isn't there lack of policies to effectively utilize their skill?
Yes, it is there. Lot of challenges in front of us to implement evidence-based nursing practice and the advanced nurse practice. Let us see what is in today's presentation. I'll just say, would like to share what is evidence-based practice and how what we are doing in PGI or my association with SIN, what we are doing over here. So what is evidence-based practice? It is integration of best research evidence with clinical expertise and patients' values. So there are three things which we need to keep in mind. It has to be the best research evidence, which is valid and reliable and credible. And we should have the clinical expertise to do it. And we should consider the patient values before implementing that. So I would tell in my own way, what is evidence-based practice? Simply for your understanding, knowing that what we do is the best practice or the nursing care that we would like to receive if we are sick. If we are sick and on that bed, we would not expect anything less than best. So we want the best nursing practice. That is what is we expect. And the only way to that is evidence-based practice so that we can implement based on the latest evidences. So what is innovations in nursing? So it's not only about generation of new ideas or inventing a new mobile application or device. It is also application of existing ideas to a new situation. Maybe the ideas are already existing, but we are putting into a new situation to improve the patient's outcome. So by doing evidence-based practice and innovations, what we are trying to do is trying to benefit the patients, nurses, and the healthcare system as a whole. So patients are going to get a lot of benefits, definitely. So this is what I was telling about best evidence and expertise and the patient's choice. So what is best evidence? When we look for the best evidence, we need to look at its relevance, whether it is current, latest, or robust, or best, whether this evidence is created based on the best methodology. So you know that evidence is a common word. It's not only seen in the research, even in movies, in investigations, we hear about evidence. It has to be best, otherwise it doesn't have value. It won't be true. So as I told, it has purpose to patients and family, healthcare providers and employers. So integration of EBP can improve the high quality patient care, and it can improve the patient outcome, and it can enhance the nurse's social obligation of accountability and gain and maintain credibility among other healthcare disciplines. So just now Dr. Shani was talking about people suspect about the credibility of the nurses. So if we implement evidence-based practice and if we are thorough with the evidences that are existing globally or in our country, no one can question our knowledge or practice. And it also will help to build a nursing knowledge base that can, nursing knowledge base, that means expansion of the body of knowledge. And it also adds to the science of nursing. It keeps practice current and relevant, and it increases the confidence in decision making. And it ensures policies and procedures are current and include the latest research. So it has multiple benefits. We have seen that. It also, when we create policies and protocols and standards, the errors and the hospital stay will be less, a lot of comorbidities and complications, and a lot of quality indicators will improve based on the evidence-based practices. So it is going to benefit the administration as well as the entire healthcare system. So journey from research to practice, we can say, especially in our country, is a road that is less traveled. But let us look into a moment on the road that is less traveled. So as I told, evidence-based practice, the steps including, we need to identify the problem that we are facing at the bedside, and so we need to search for the best evidences across the global literature, and we need to see the appraise, or we need to see how good that evidence is, whether it is practical in our setting, and if it is so, through various quality initiative programs, we need to implement that evidence, and following that, we need to evaluate it. So this is one of the important area for transforming the care at bedside. We do many procedures, many things we do, when many of them don't have scientific evidence base, though the experts have developed, because many of the practices which we are practicing, which are being developed before many years at the origin of nursing, without much evidences. Though the statistics and research, Florence Nightingale has brought in, we know that she's not only just a lady with lamp, but she was a very good statistician and researcher. So it was there, but still many of the practice we do are without scientific database. So as I told, the steps of evidence-based nursing practices: ask, acquire, appraise, apply, and analyze. So we need to find the problem, put the best evidence, find the best evidence, and implement it and evaluate it. So first, as I told you, identify the gap. Either we create the evidence through research and meta-analysis, or identify the evidences which are already existing in literature. And then selecting and developing protocols or standards or guidelines or SOPs as per our situation, and whatever whether protocols or SOPs, guidelines that we develop, we need to communicate and train the nurses. This is one of the lacuna which happens many times. We need to communicate and train the nurses. This is how you have to do it. This is how it can have impact. And these are the parameters which we are going to monitor based on to assess its effectiveness. And then with the quality improvement initiatives, using multiple PDSS cycle, we need to implement them. After implementing them, we need to evaluate them. So what can be some of the tools to implement evidence-based nursing practice? So it can be some of the evidence-based protocols, SOPs, intervention packages, bundles. We all are familiar with BAB bundle, CLAPSI bundle, COTI bundle. Now recently we have developed a dietary diabetes insipidus bundle. So various care intervention packages are there, SOPs are there, protocols which are already published or are already existing. And we need to, after implementing these protocols and policies or the intervention with packages, we need to assess its outcome. How can we assess the outcome? We can use various checklists when Dr. Shani was highlighting about the need of it, and need identification questionnaires of checklists and various questionnaires which are already existing, or we can develop. See, there are, I'm working in neuro, so we are developing some kind of checklist to improve the practice and to assess the effectiveness of various intervention objectively through this checklist. So recently we were developing a need identification checklist for the patients of SH. When the patients are coming for follow-up, how can we assess what problems they are faced, and various scales like Glasgow Coma Scale, Outcome Scale, Barthel Index, so many scales we can use. As I told, we do, after developing all these things, we need to engage and educate. So the staff members, the healthcare team, we need to communicate and educate them about our intervention, and then execute and evaluate. So whenever we plan any intervention or policies, there are three things which you have to keep in mind, that is based on the Donabedian model, or whenever before we implementing into a quality initiative step, we need to focus on structure, process, and outcome. So what all modifications we can make in structure? Maybe some of the interventions may be only focused on structure, some may be only process, some may be focused on both structure and process, and that both can impact outcomes. So we have to be wise enough. Usually quality improvement initiatives are little large scale initiatives where we focus both on structure and process, and it may not be a one-time implementation. We do multiple PDSA cycle. We plan as some of the interventions, plan it, implement it, and then we study the effectiveness of it. And if it is okay, we will go ahead with this. Otherwise, we will add on intervention, or then again, it's a multiple cycle of PDSA cycle that we need to do that. So who will implement innovations or evidence-based nursing practice? Is it the duty of diploma nurses, graduate nurses, postgraduate or specialized nurses? You know that all the postgraduate nurses are specialized nurses. So their skills are being underutilized in India. Or PhD nurses, or is it the duty of the nurse administrator, educators, and researchers? So here I am as an educator working in a college of nursing or National Institute of Nursing Education, PGI. And I myself can say that I'm a researcher as well. And I collaborate with the nurses, the nursing service side, with the administrators, and then take up many initiatives to improve the quality care of the patients. So is it the research and evidence-based nursing only for these people, or for the PhD nurses or the graduate nurses? No. Even graduate nurses and diploma nurses also can be part of this initiative, but maybe the major lead may be taken by the postgraduate nurses or the PhD nurses, because they during this specialization we learn in depth about research, evidence-based practice, and a lot of techniques of conducting and implementing these things. But graduate nurses and diploma nurses will always be in the team to implement this, and without their support, it is a teamwork. Without everyone's support, we can do that. So nowadays, all the more we have research, specialization, short course. So this all should add and initiate or enhances more and more evidence-based nursing practice and quality initiatives to improve, to fill the gap between this and practice. So some of the initiatives of my own, which I would like to, or as a team we have done in our institutes, I would like to share with you. So this was my master's study, which I had done in AIMS in collaboration with neurosurgery department. That was nutritional status in patients of severe head injury or traumatic brain injury. So which shows that there is nutrition depletion over the time. We need to start early enteral feeding. The nutritional depletion affects the result in various complications, and even including pressure ulcer. So all these things we have published, and one of our publication is being even quoted in the guidelines for the management of severe traumatic brain injury, 4th edition by Brain Trauma Foundation. So you can see that they have guidelines. So when we do a good study, when we create evidences, they become the part of global guidelines in the management. So not only we are able to transform the health care at the bedside, we can also impact the care globally. So that's the importance of research and evidence-based nursing practice. So during my PhD, what I studied was impact of cognitive and behavioral changes on caregivers' psychological burden. So we know that behavioral symptoms in the patient can result in poor psychological well-being among caregivers. So we have found that there are neuropsychiatric symptoms, cognitive deficits, and there are various factors affecting. And these all are the common behavioral changes which actually really give trouble to the caregivers. And so, but after completing my PhD, I did not limit there. I extended my work towards the same aspect in TBI, and in stroke patients as well. So this is stroke. So by mistake, I have written here TBA, stroke patients as well. And we found that almost similar behavioral changes are there among these patients. I remember when I was collecting the data of the brain tumor patients, one of the patient's caregiver was telling, even if that patient was suffering with a lot of irritability, agitation, anxiety, depression. No, so she was explaining to me, if my patient was fully quadriplegic, I would have given proper care. I would have even had more peace than this. Would have taken care of him so well. But now he doesn't cooperate with me for anything. When I go with food, he doesn't want food. And odd times he wants food. When I give medication, he spit it out. He beats me, he pinches me, he does this, he doesn't cooperate physiotherapy. Lot of behavioral symptoms which literally give a lot of burden to the caregiver. So these all changes can result, and even similar to this, even literature also have shown many of that. So these are the common one from which we could identify. So it is not only the psychiatric symptom had the maximum impact on the caregiver burden. So we felt that, that when the patients are coming to OPD, doctors will definitely, assess the physical symptom. The rehabilitation process will definitely focus on the physical symptoms, but very rarely neuropsychological rehabilitation goes on. In our department, we have one neuropsychologist who can't deal with all these patients. So we thought that how can we manage? So the process of neuropsychological rehabilitation includes proper neuropsychological assessment and providing individualized intervention to those patients since the time of your hospital stay and even after the discharge. So who can do it? I told you that we have only one neuropsychologist who is also responsible for many other work. So we found a master's neuroscience nurse, and trained her on neuropsychological assessment and implementing providing brief counseling during the hospital stay of the patient, and to follow up the patients in OPD and providing the counseling through a neurosurgery nurse-led clinic. So this initiative we thought of and we further study. So before that we had conducted a brief nurse-led intervention for the alcohol hazardous or harmful alcohol use. So that came to my mind. That is how we thought of actually developing a brief counseling, nurse-led counseling for these patients. So we developed it, and with MSc, with the help of MSc students only, we developed it. Then as a study of them, we developed it with the help of neuropsychologists, psychiatrists and neurosurgeons, everyone. And then we found that it's published in a very good journal, also found that it reduces the number and severity of the behavioral symptom, and it reduces the caregiver's stress. So we developed a SOP for the nurse-led neurosurgery clinic, what the neurosurgery nurse will do over there, what will be their job responsibility, what will be the objective. So this is how a neuro nurse will be assessing the patient, and if the patient needs brief counseling, she will provide that, and physical and training needs also will be identified. And if the patient is having more psychological symptoms, the patient will be referred to the neuropsychologist. So like I focused to implement this, I really focused on the structure, process and outcome. So we had developed with because of lack of time, I'm not going to the details, but with a lot of struggle and support from the neurosurgery and other departments. Since I had the data, I always believe that data has power. So with that data only, I played for 1 to 1.5 hours to generate my structure, the process, and we had objective outcome measures to assess at the end of the program, whatever we are doing, which we are doing currently also. So maybe 1.5 years it took to create this post and implement this neurosurgery nurse counselor post and the nurse-led clinic. So on non-OPD days, she will be visiting the patients at the bedside and assessing their providing neuropsychological brief counseling. And on OPD days, the patients who are following up, she will be addressing in detail. So implementation phase was like we had a well-defined plan. We had taken permission from stakeholders, and we created a post of neurosurgery nurse counselor, and then we initiated a nurse-led clinic by neurosurgery nurse counselor. So this is how she works in the clinic. She also, this is the need identification checklist that is developed for assessing the needs of the patients. You can see here physical needs, practical needs, emotional, family, caregiver needs, even training needs, etc. So she may assess using various checklists, brief nurse-led counseling, referral, teleconsultation. And so these all are various tools we have used. So to assess their outcome, we have functional outcome of the patient. We are assessing quality of life, care practices, psychosocial outcome of patients and caregivers, caregiver burden, patient satisfaction, number of referrals. We could find with our data so far, all these aspects are really improving with the nurse-led counseling. So there's a short article which we have published on the neurosurgery nurse-led clinic research to practice, how we have initiated this, what was the thought behind it. So there were certain barriers. It was a long process. Convincing the stakeholders to achieve all these things was difficult. So somehow with the hard work and the perseverance, we could overcome. So other initiative that we have in PGA is stroke nurse. That's the role of stroke nurse is very important, from prevention in emergency, during the hospital stay, at bedside, even during the follow-up. So we have a code stroke over here. As soon as a patient comes, we will activate the code stroke, and all the code stroke team members, including neurologist, neuroanesthetist, and stroke nurse will reach the emergency. And the stroke nurse will take the lead role while the neurologist will assess the patient. She will also assess the patient, and she will coordinate everything to shift to assess the eligibility for thrombolysis, to arranging for the CT scan, and to arranging the CT angiography, and all those things she will coordinate, and so that we will be able to reduce the, if patient needs mechanical thrombectomy, that she will coordinate. So the door to needle time and the door to CT time, and for the mechanical thrombectomy, that is door to catheter time, was reduced when stroke nurses were implemented in our institute. We have 3 stroke nurses, so we are training them. We have developed guidelines for them, and also we are through our SIN course, we are training more nurses from even from various part of the country, even from our institute, so that we can further enhance the care. So the stroke nurses also will take rounds in the patients, so to the patients who are admitted in stroke ward. So because the nurses who are really working in the stroke unit, all are not stroke nurses. So they will guide them, they will help them to plan and deliver their interventions, etc. They will also visit the patients in OPD for providing support and follow-up care to the patient. They also focus on the caregiver empowerment, and it is also based on multidisciplinary approach where speech therapist, physiotherapist, and neurologist, neuropsychologist, and everyone together we implementing this program. So you can see here that once the neurosurgery, stroke nurses were there, you can see the door to CT time and the door to needle time was reduced. They also focus on rehabilitation, community integration of the patient, everything. So they play a lead role in that. So other initiatives we had in stroke nursing is we have this is an initiative of SIN, Society of Indian Neuroscience Nurses. We have developed a stroke nursing certification course in collaboration with ECHO platform, ECHO India. Me and Shani, Dr. Shani, both are the course directors. With the support of SIN executive members, we could implement that. So for 2 courses are conducted, 16 nurses are trained on this. In future, we are planning to do it in a hybrid model. So where nurses can be trained and they can be placed as stroke nurses. In future, I'm sure that in India also there'll be specialized nurses working in every field. So this will be definitely going to be useful. So now then we have developed in stroke, we have developed stroke nursing guidelines. You know that AHA has developed guidelines for stroke care. But here we know that the stroke nursing guidelines, every phase of the care, what nurses have to do, is being explained or depicted in this stroke nursing guidelines. Then enhancing stroke research, and we are conducting various systematic reviews and meta-analysis on quality of life, as well as we are also doing the various the risk factors of stroke, etc. Then we have also created stroke caregiver and support group in our institute, which is first of its kind in our country. And we have tele-stroke to follow up the patients, especially during COVID. It was very, very effective and useful. And we have various app-based interventions like mirror therapy. And we have developed a discharge teaching plan based on the mobile app implementation initiative. And another aspect is we have developed a dietary diabetes insipidus bundle in pituitary region tumors. So we know that postoperative pituitary patients suffer from DA and hypernatremia, and they require vasopressin, and it may prolong their hospital stay. We have developed a dietary diabetes insipidus bundle, which is first of its kind in world. So we have published in Journal of Advanced Nursing as well. It really flattens the DA trend with the significant benefits in polyuria, hypernatremia, and reduced vasopressin requirement and reduced duration of hospital stay. So other few initiatives we have done in PGAs, we have developed and implemented communication board for the conscious patients to communicate with the caregivers or the family members, which was really helpful in reducing the anxiety, and it helped them to express their need and reduce the anxiety of the patient. Other initiative is cryotherapy that we have developed and implemented. This is to reduce the periorbital edema postoperatively that is developed among the neurosurgical patients, especially supratentorial craniotomies. Then auditory stimulation for the coma patients. It's a family caregiver based intervention. We know that we always say that we need to talk to the patients. Okay, as nurses, we may be talking to the patients whenever we do some procedures and other things. Yes, we are doing this, that, and all these things, fine. But in a routine, when the caregivers are coming to visit, what they will talk to the patient? They will come and ask, are you all right? How are you? Which they can't, because we believe that the auditory sense is the one which is lost last. and we encourage communication, right? We believe that they are able to hear. So they'll be asking to the patient who is now at that particular point of time feeling hopeless, helpless, and worthless in that particular situation in the coma, if they are having some kind of senses. So based on these three things, we focused our intervention, and we developed a narrative story by the family caregiver to be communicated to the patient morning and evening when they visit them, very near to the ear of the patient, so that they will be able to hear as much as possible. So here we emphasized that instead of just going and asking, this is what usually happens. How are you? How do you feel? You are all right. You will become all right. And after that, the caregivers just stand like this because they don't know what to speak. They literally don't know what to speak to the patient because the patient is comatic. So we told them to talk to the patient, narrate the story of their family every day morning, so that they feel they're helped, and they feel worthy, and they feel hope. We tell them that you are getting all right, you are in the best hands of in the hands of best doctors and the nurses, and in house everyone is fine, children are going to school, you don't worry, there are people taking care of, everything is going on smooth, and you are very important for you, for us, we are waiting for you to come back. So this kind of which will feel the patient worthy, helpful, and that feel helped as well as hopeful. So this also a study which was showing that a lot of changes in the vital signs, and but it was a short follow-up study where we could not.
Dr. Manju, can we wind up? We are going beyond time. Thank you so much.
Okay, sure. So that was one of the study, and we are also developing pituitary guidelines, some for nurses, lumbar spine surgery guidelines for nurses, and need identification checklists for SIH patients, and various quality improvement initiatives. So we are also doing, this is the recent systematic review which we have done to change the practice of hypothermia implementation. So because it was showing that treating intracranial hypertension can have, with hypothermia can have some effects, but has many adverse effects as well. This is the implementation of use of ORS solution for the hyponatremia that is developed in patients of traumatic brain injury patients. This is progressive muscle relaxation and deep breathing exercise on chronic tension type headache patients, which showed that their sleep quality, pain, and disability was improved. So this is another concept we have developed, though not related to neuro. We have also implemented. We had an orthopedic and rehabilitation nurse who have passed out last year, and we were trying to utilize her specialized skill, and we have incorporated in multidisciplinary amputation clinic as an amputation nurse. She also visits the patients from the time of admission till discharge and during the follow-up. So during the COVID, we have done multiple studies on patients, as well as we also focused on nurses' welfare, burnout and various challenges, resilience, many aspects we studied, in fact, as well as not only other than COVID, we also are studying the CVD risk factors. We have studied in India, and I mean in PGA first, then as a multi-centered study, we have developed a web page to implement the interventions for NCD prevention for the nurses, and now we are doing it across the North India. So we have also developed an evidence-based nursing care guide for critically ill patients with COVID-19 based on a scoping review. So which was really useful in our institute and many other institutes where nurses can know what they have to do. So whatever we do, we should be publishing so that it doesn't stay near the bedside of our patients, it goes across the globe. So we know that the nursing specialization is not only benefiting the patients at bedside, but at the all preventive levels and in education, administration, and everywhere. You know that a nurse administrator or a nurse educator who is having a specialization will definitely make an impact in the outcome. So as I told, there is health outcome benefits for the nurses based for evidence-based practice. So nurses need to be really empowered. They should not stick to what they have learned, but they should be updating their knowledge and based on the current practice. So they should be ready to redefine the nursing so that the nursing is recognized among the society and among other healthcare disciplines across the world. So evidence-based nursing practice will help in enhancing contribution of nurses towards improving the healthcare outcome of the country by raising the standards of nursing education, quality of nursing care practices at par with global standards.
Manju, are we done? We are already 15 minutes beyond time.
Yeah, it is done. So everyone is important. The little drops of water make a mighty ocean. We know that. So start wherever you are, use what you can and do what you can. So that's what my philosophy and thought. So thank you so much. You know that I crossed time, I think. So however, thank you so much for inviting and giving me this opportunity. And I'm so happy to see my friend Manju and all other organizing committee members with whom I have communicated a lot for seeing me first time.
So thank you, Dr. Manju, and I don't think so because you have spoken so much, and I'm sure that the nurses in this forum will have a lot to search and read about. So I would not take much time about it, but I always found that the nurse who is there, a neuro nurse or a stroke nurse, she would not only find a deficit physiologically in a patient, but she'll also try to see how best she'll be able to restore, though it will take time. But definitely she will try and see how she'll be able to make that improvement in the patient's life. So thank you so much, Dr. Manju. Handovering back to Sridevi ma'am for the questions, or how do we take it? Back to ma'am.
Thank you so much, Dr. Sneha and Dr. Rita for moderating these sessions. Participants, we're extremely sorry we went 15 minutes beyond time, but Manju Dandapani, as I know her, has been my inspiration too, though she's much younger than me. And the kind of work she does has made me think that it is worth a PhD, because till now, honestly, I'll tell you, it has been very rare people, or I haven't found anybody in India using their PhD knowledge as much as Manju. So well done, Manju Dandapani. Thank you so much. And before we kind of have a small photograph session, there are no questions in the chat box. So I'm not going to, and we are not going to take any questions. We were planning for some, but we are really beyond time. So we don't test patience of our participants. I thank sincerely Gapio, the chairperson and the secretary, and Dr. Tandon, Dr. Anupam Sibal, Dr. Ranjan, and all the members who allowed us to use this platform effectively. And especially our team, our organizing team, as I already said, led by Dr. Usha Banerjee, our moderators, Dr. Rita Lakhani and Dr. Sneha Vaidya, for a fantastic job that they have done. Our speakers, Dr. Manju Pallam, Dr. Shani, and Dr. Manju Dandapani, two Manjus here. Amazing. And I think, I mean, though it was beyond time, we kept listening to them. So both the Manjus did take a little extra time, but it was worth everybody. I hope the participants really enjoyed listening to this talk. And before we leave, we request that a print screen be taken for evidence. And actually speaking, there are a lot of comments that we have, or a lot of questions that I wanted to ask even, but we won't take the time now. So thanks once again. So if we have somebody has taken the photograph, then we wind the session. And all our dear participants, we thank you for your valuable attendance. We see photographs of Apollo Hospital nurses attending in groups. I think continuing education is the only way forward for Indian nurses. And so every day we have to be ready to learn, because we are doing what 4 years we are taught, which is basically outdated in the next 4 years. So until we get onto protocols, guidelines, and checklists, and keep them at the bedside, what we learn in our degree courses are not going to be useful. This is my 2 cents for somebody who is almost retiring from education, but we really think that's the guide that we want to give youngsters. So please get up to date with things, and we thank you for your time. Thanks a lot to everyone here. Bye-bye from me and from the session chair, as well as from everyone else. Thank you so much.
Thank you, Ms. Sridevi, the entire organizing committee, the speakers and the moderators. I just want to make an announcement that Dr. Sushil Jain, whose video is just up, has taken over from Dr. Tandon. And thank you, Dr. Sushil Jain, for allowing us to host this wonderful session. Thanks to all the backend team who have worked hard to bring this live today without any glitches. So thank you once again. So Dr. Sushil Jain, do you want to close on a few seconds remark? We can't hear you.
Yeah, I was unable to unmute. So thank you, Captain Usha, for the introduction. And now onwards, I'll be taking care of the responsibilities which were earlier taken care by Dr. Tandon, and would be a pleasure working with you all together. Thank you very much. Thank you.
I think Dr. Tandon is also on this session logged in. Thank you so much for all what we have got from you so far. Thanks to everyone as the organizing committee for making this happen today. Thank you, Ms. Sridevi, for being a wonderful chair.
Thank you so much, everyone. Bye-bye.
Bye-bye. Thank you so much.